Thank you.
So, hi. Hi, good afternoon. So my name is Binsi. I'm the Heart Failure Services lead from BHRUT. And along with me is Dr. Saad Sahicha, who is also the consultant cardiologist, and Caroline Seventh, who is a heart failure nurse as well. So together we're going to present this topic on heart failure. Can you guys hear me clearly?
Yeah, we can hear you clearly.
Oh, thank you. And so is there anybody, can you put the videos on? Can I see? I feel like I'm seeing a black screen with some names here and there. Is there anybody who, can you put the videos on by any chance? No? Okay.
Yeah, so we've got, I can see Tracy, Susie.
Okay,
Atia.
thank you.
Yeah.
Thanks a lot. I think I'm the one who's not seeing much, but anyway, thank you. So basically, the topic is heart failure, and I just wanted to ask a simple question. What are the signs and symptoms you can see in heart failure, right? Can I get some answers?
All of them?
All of them, good. Thank you. Any more yes or no's or? Okay. Okay, all of them. I think I can see all of them much more common there. So, yep. Thank you. So that is what so I know you guys, we were told that it was a wide variety of people. So we have made it as simple. So if please forgive us if it's too simple for you guys, because we are just trying to, it's present to everyone. So please forgive us if it's too simple. So basically, to start with, I'm going to ask Temi to help me with the slides. So Temi, can we go to the next one, please? So what is heart failure? So basically, heart failure is a syndrome in which patients should have the following features. So there are two types. So one is they should have symptoms of heart failure, or they should have objective evidence of abnormality of the structure or the function of heart at rest. So they should have both of them. So either they should have the symptoms of heart failure, which, as you have all said, it should include shortness of breath at rest or on exertion, fatigue, and then if you have signs of fluid retention, which can be either pulmonary congestion, ankle, peripheral edemas, and abdominal distension. And also the second thing they need to have is evidence of abnormalities of the structure or the function of the heart at rest. Second slide, please. So heart failure is basically a clinical syndrome, and the cardinal symptoms, the main symptoms you could all see is breathlessness. That's what the patient would say, breathlessness, swelling of their ankles, and fatigue. The signs you can see is peripheral edema, raised JVP, and crackles. They are caused by your structural or functional cardiac abnormalities, and this results in reduced cardiac output and elevated intracardiac pressures. So next slide, please. So this heart failure is often associated with marked reduction. As we said before, it really leads to a marked reduction in the quality of life. And so it's a more of a debilitating condition where the patients feel like it really affects them, their life altogether, their quality of life altogether. They have increased morbidity, mortality, and they have a high risk of readmission. So that is the reason why we need to try to diagnose heart failure earlier. Earlier diagnosis, better management as well, because 900,000 people in UK is currently living with heart failure. And this admission accounts, the heart failure care, and accounts to about 2% of the annual NHS budget. Can we have the next slide, please? So types of heart failure, can anybody tell us, according to their left ventricular ejection fraction, would you be able to tell me what are the types of heart failure you see? Any answers? I have the slide in front, so if you want, you can read through it. Okay, I can see they're a very shy group. So let me try to say. So we have three types according to the left ventricular. We like is the ESC guideline says there are three types of heart failure according to terminologies based on their left ventricular ejection fraction. That's the capacity of the left ventricle's pumping ability capacity. So it's called heart failure reduced ejection fraction, and this is the maximum. We say they are the patients who have ejection fraction less than 40%. And then we have heart failure mildly reduced ejection fraction or mid-range ejection fraction. So these are the patients which are neither in the reduced ejection fraction nor in the preserved ejection fraction. So they are somebody who have ejection fraction ranging from 40 to 49%. So, and the heart failure preserved ejection fraction is obviously the ones who have ejection fraction over 50%. So we have we have reduced ejection fraction is less than 40%. If we have a mildly reduced ejection fraction, we have 40 to 49. And then you have the HFpEF, which is the preserved ejection fraction, which is over 50%. And both in the mildly reduced ejection fraction and the HFpEF, you have to have also raised BMP levels, and also one additional criteria, like they should have either a structural heart disease, like you will have a left ventricular hypertrophy or the left atrial enlargement, and diastolic or the diastolic dysfunction. So these are the things which you will see in both of them. With the heart failure reduced ejection fraction, you have certain prognostic medication, which Dr. Sahicha will be talking about in the going forward. With the heart failure mildly reduced ejection fraction, these and the HFpEF, usually they are managed by, if the patient have signs of fluid overload, you give them diuretics, or you actively manage their comorbidities. That's how we manage these patients. We have the reduced ejection fraction. Obviously, we have a proper management, like what all medications we can start and what all devices we can devices which we can offer. Any questions still here? Am I too fast, or is it okay? Chats. Okay. So far, no answers. So I'm just going forward. I can't see you guys. So maybe if I'm jumping forward. Oh, thanks a lot, Tracy. I can see only one or few people on my thing. So please bear with me if I don't ask every one of you. So the next, can we go to the next slide, please, Demi? So the next slide is, as we discussed before, when to suspect heart failure. And as you guys have already said, if you find there are symptoms of shortness of breath at rest or exertion, if you find the patient is complaining of fatigue, or if patient has signs of fluid retention, these are the patients you are going to suspect they are having heart failure. So can we have the next slide, please? So these are the clinical features of acute heart failure. So on one side, we have put on parts of fluid overload or congestion, and the other side is hypoperfusion. So the main symptoms with fluid overload you can see is orthopnea, where you feel the patient finds it hard to lie down flat. They always, they tend to, you can ask this question by simple, how many pillows do you need? Have you noticed that you have increased amount of pillows while sleeping? Sorry, Tracy can't see the slide. Is there any?
Sorry, I can't see what slide.
There's a message that I can, some of them can't see slides, but some can.
Okay, maybe you just need to log in and log out again.
Sure. Sorry for the inconvenience. We'll try to sort it out. I can see the slide, but obviously. Here, can you see this slide? When to suspect heart failure, Tracy?
Oh, I can't. I'll log out and log back in again. Can everyone else see it? Yeah.
Yeah. Most of them can see it, Tracy. So. Okay. Can I continue, Tammy?
Yeah. Yes, go ahead.
Okay. So the other, as I said, the clinical features, as I said previously, the fluid overload you can see is orthopnea. As I said, It's easy way to find out is if you ask the patients, do you feel that you need an increased number of pillows while sleeping? So because patients do suffer from, they complain that they can't sleep flat, they need to sleep upright, or they have noticed they need increased number of pillows. So that's called orthopnea. And then we have PND, or paroxysmal nocturnal dyspnea, when the patient complains that they wake up feeling breathless, or some people say they feel like they're gasping for air, or they feel like they're drowning. These are the signs of fluid overload. Also peripheral edema. This is something we can see. You can see swelling which starts on the ankle. It can go up to shin. It can go up to the thigh. Some people have it on the private areas. Some people end up having abdominal distension, sacral edema. So this is like a widespread, you can see. Also, you can also notice a raised JVP, or the jugular vein pressure. So you can, when you assess the patient, you can see the JVP is raised, and you can auscultate. You can see a crackles, creps as well. Obviously, you can also see hear a gallop rhythm, and notice ascites. That's also another thing we can see. And also we find out hepatic distension. The other side is called hypoperfusion. So this, because when heart failure occurs, you also tend to have hypoperfusions because it's not enough blood supply. So we can see signs of tachycardia, narrow pulse pressure, cool extremities, and poor peripheral, poor capillary fill, confusion, some people, oliguria, dizziness, and they can also complain of lactate. This is usually in the hospital settings we are able to find out much easier. So, but the only thing we wanted to prove in this, that hypoperfusion is not synonymous with hypotension, but people always associate hypoperfusion and hypotension. So that's the reason why we put that slide there. Can we go to the next slide, please? These are certain pictures of what you would see. You can see the edema, peripheral pitting edema. That's if you press it, you can see your hand, your finger. You can see the mark of your finger on the patient's leg or on their. I think this is called signs of. This is our signs you can see. So can we go to the next slide, please? So the next slides onwards, I think Dr. Sahicha will be letting you know about the investigations and about medications and device therapy. If you have any questions till now, you can ask now, or you can wait till the end of this the session.
Thank you, Bincy.
Thank you.
If there aren't any questions, I'll carry on. I'm Dr. Sahicha. I'm a cardiologist based here at Queen's and King George Hospital. So in terms of the investigations that you'd want to do for heart failure, the key test really is the NT-proBNP, the brain natriuretic peptide. And that's elevated with any sort of structural abnormality to do with the heart. So it's very good. A negative BNP of less than 400 is very good at excluding heart failure. Can you hear me?
Yes.
Oh, I think there's some feedback. Can you hear me?
Yeah, I can hear you.
There's some feedback that not everyone can hear. It's a bit of a mixed feedback.
Yeah.
Let me try and. It's quite. Is that any better? That's very faint.
I can hear you clearly.
Yeah, I can hear fine.
Yeah, does everyone want to put their speakers up also? Because the recording's pretty loud.
Is it?
Well, for me it is. I've got my speaker all the way to the top.
Okay. I'll speak louder and see if that helps. So I don't know how much of that you heard, but my name is Dr. Sahicha. I'm a cardiologist at King George and Queen's Hospital. I'm just going to talk about the investigations for heart failure. So the key investigation is the NT-proBNP, the brain natriuretic peptide. And that's an excellent test for excluding heart failure. So if the value is less than 400, you're very unlikely to have heart failure. If it's elevated, it can be elevated because of heart failure, but it can also be elevated for other conditions as well. Would anyone like to suggest some conditions that your BNP can be elevated in, but not have a diagnosis of heart failure? Are there any suggestions from the old age? Possibly. Anything else? Not one that comes straight to mind, but I think if you tend to be elderly, then you may have, renal dysfunction, which may increase your BNP. But I mean, old age per se, I don't think is a reason for the BNP to be elevated. PE, yeah, that's a good one. So the PE will cause a rise in your BNP acutely. Do you know why that is? Why would PE cause a rise in the BNP? Yeah, good. So yeah, good. Yeah. So so right ventricular stress. So there's increased hemodynamic effects because of the PE. So any sort of impact this has on the heart will cause the BNP to raise. The other sort of common condition that can cause it, another cardiac condition that we see a lot of patients being referred to the BNP clinic with. There's another common cardiac condition that puts it up. LVH, yeah, good. So hypertension, LVH. Another common condition that you might come across. Cardiac condition. Yes, excellent. AF. So atrial fibrillation causes an increase in the left atrial dimensions, the left atrial remodels, and that can put your BNP up. So essentially, anything that causes a change in the structure of the heart or impacts on the structure of the heart or the function of the heart has the capacity to put the BNP up. The BNP is important. What about, yeah, HOCM? Yeah, that's a good one. That will put your blood pressure up as well. What about full blood count? Why is that important for patients with heart failure? Because as Vinci mentioned earlier, excellent. Yeah, so these patients, they present with breathlessness, and you want to exclude anemia. Often patients with heart failure do have the iron deficiency, so you'd want to check their iron, the hematinics as well. Use and ease. Why would that be important for a patient with heart failure? Well, it can help in terms of prognosis. We know often that patients who have poor renal function and poor heart function, that's not a very good combination. It can also help in terms of tailoring medications such as heart failure medications can, exactly, they can affect, it's coming here, AKI and diuretics. So the medications that we give to treat heart failure have an impact on kidney function. LFTs, if you've got poor LV function, that can sometimes cause hepatic congestion and derangement of the LFTs. TFTs are important because you want to exclude, thyrotoxic state or hypothyroidism, which can be associated with heart failure. So it's important, and glucose to check for diabetes. So there's important sort of baseline tests that you do, including the BNP. It's also quite important to do an ECG. Why would an ECG be helpful in someone that you suspect has got heart failure? What would you be looking for in an ECG? Yeah, good. So underlying ischemic heart disease. So there might be pointers as to the etiology of the heart failure. So they might have, Q waves anteriorly. They might have had a previous anterior infarct. there might be some ischemic changes on the ECG. Often you get bundle branch blocks that can be associated, a left bundle branch block can be associated with hypertension. It can be associated with heart failure. And we'll come on to talk about that a bit later on. Chest X-ray is important. What would you expect to see on the chest X-ray? Yeah, so you'd see an enlarged heart or lung pathology. So you may see cardiomegaly. You may see that the cardiothoracic ratio is greater than 50%. You may see signs of pulmonary edema. The echocardiogram is important because that gives you, the left ventricular function, and that can give you an idea of the underlying etiology. Does anyone know what they would look for in an echo in order to decide between a particular etiology? Would they, if you received an echocardiogram from the community, what sort of telltale signs would there be with regards to the etiology? So I think good. So valvular problems, pulmonary artery pressure, ejection fraction. So excellent. So all these causes of heart failure. So valvular disease is important. Do they have underlying hypertension? Do they have LVH? Is that the underlying cause of the heart failure? You want to see what the ejection fraction is, so you can put them into those different brackets. Is this heart failure with reduced ejection fraction, mid-range ejection fraction, or preserved ejection fraction? I think one of the key helpful indicators is whether there's regional motion abnormality or whether this is global dysfunction. So if it's global dysfunction, that tends to point towards, perhaps a dilated cardiomyopathy, perhaps a history of alcohol excess. Whereas if you've got regional wall motion abnormalities, that points more towards an ischemic background. So I think broadly speaking, when you look at the echocardiogram reports, if there isn't any significant valvular disease, I would look at the nature of the dysfunction as to whether it's global or whether it's regional, because that can give you not always, but that can give you an idea of what the underlying etiology might be. And you need to try and fit that in with the clinical context. In terms of further imaging, you can do cardiac MRI scan, myocardial perfusion scan, and coronary angiography, but that was something that would usually be organised via secondary care. Next slide, please. So natriuretic peptides, as we said, they're increased whenever there's any change in the loading conditions of the heart, and they're excellent at excluding heart failure. When they're elevated, they can point to the severity of the heart failure and the need for assessment, the urgency of the need for assessment. But you need to treat elevated natriuretic peptides with a bit of caution, because they can be elevated with other common conditions, particularly CKD. Atrial fibrillation is the other big condition where it tends to be elevated. Next slide, please. So in terms of the ECGs, they're rarely normal in heart failure, and they've got a good predictive value. And it can give you an idea of what the underlying etiology is. Does the patient have atrial fibrillation that's poorly controlled? Do they have a tachycardia-induced cardiomyopathy? Do they have a left bundle associated with hypertension? Do they have a dilated cardiomyopathy with broad left bundle? So the ECG can give you some ideas as to what the underlying etiology is, and is an important investigation for heart failure. Next slide, please. So as we alluded to earlier, you can see this is a classic chest X-ray of a patient with heart failure. You've got blunting of the costophrenic angles, and you've got pleural effusion bilaterally. You've got a raised, increased cardiac size with cardiomegaly, and you've got congestion in the hilar consistent with pulmonary edema. Next slide, please. So the echo, as we alluded to earlier, is the gold standard test, and that helps to differentiate systolic and diastolic dysfunction. And importantly, it gives us the ejection fraction, which helps us guide medications and guides how we treat patients according to the prognostic medications. Next slide, please. So in terms of the management of heart failure, there's the pharmacological therapies, device therapy, and bridging and transplantation. So next slide, please. So there's really, there's four pillars in terms of, so this is for the treatment of heart failure with reduced ejection fraction. So those patients with an ejection fraction below 40%, there are four pillars of treatment. So there are four prognostic medications, and this really is a take-home message in terms of the treatment of heart failure with reduced ejection fraction. So you've got ACE inhibitors, or ARNIs, which are angiotensin receptor neprilysin inhibitors, sacubital valsartan. There's beta blockers, and there's MRA, or mineral corticoid receptor antagonists. And a more recent addition to this are the SGLT2 inhibitors, dapagliflozin and empagliflozin. And these have been shown to help reduce hospitalization and mortality associated with heart failure. Next slide, please. So this is taken from the ESC, the European Society of Cardiology, and you can just see it at the top. You've got the four key prognostic medications. So your ACE inhibitor or your ARNI, which is your angiotensin receptor neprilysin inhibitor, your beta blocker, your MRA, and then your SGLT2 inhibitors. Those are the four prognostic medications, and there's a class 1 indication for giving patients the medications. Diuretics don't have a prognostic benefit, but they can be used to help congestion. So it's really, there's been a sort of change in the way we manage patients with heart failure. So we used to start off with, analogous with the trials, you'd start off with your ACE inhibitor, you'd up titrate that, then get them onto a beta blocker, and then your MRA. But now that the sort of school of thought has changed, that these medications are complementary, and it's best to try and get patients on small doses as quickly as possible. So rather than that sort of approach, the stepwise traditional approach, which sort of correlated with the trials, it's the school of thought is now to try and get patients on these medications as quickly as possible. And something that may have taken 6 months before, you're looking at trying to do, in around 4 to 6 weeks. So you want to get these patients on optimized on these four medications, and then once they've been optimized, you want to assess them for whether they would require a device. And the cutoff figure is 35%. So I think you just need to be aware that patients with an ejection fraction of below 35% who are optimized may be a candidate for a defibrillator or a cardiac resynchronization therapy device. Next slide, please. So this slide's a little bit busy, but this just shows that just to be aware that for patients with heart failure who are optimized with an ejection fraction that remains below 35%, you can consider them for a defibrillator or a cardiac resynchronization therapy device. And that's based on the left bundle branch block, because the left bundle branch block gives a measure of desynchrony and how well they're going to respond to cardiac resynchronization therapy, and also the NYHA class status. So this is taken from the NICE guidance on device implantation. Next slide, please. So yeah, this is a device where you can see three wires. This is a CRT-D device, and you can see there's a battery that sits on top of the muscle. There's a wire that goes into the right ventricle, and there's a wire that goes into the left ventricle via the coronary sinus, and that's not in the left ventricle per se, but it's in the epicardial drainage of the left ventricle, and then there's a wire in the top there in the right atrial appendage. So this is a CRT device. This helps to resynchronize the heart pump, and patients with a broader left bundle get a better effect. Next slide, please. So I'm just going to, I think this is going to be taken on by one of my colleagues, the next few slides. I'll take any questions at the end.
Hello there. Sorry.
Great, yeah. Carry on.
Yeah, I'm Carol. I'm one of the heart failure nurses. I'm sorry if you can't see me. I couldn't connect to the computer, so I'm on my iPhone. So if you can bear with me and just listen, if that's okay. Can everybody hear me?
Yeah, we can hear you.
Okay, hello there. Yeah, what I'm going to speak about now is about palliative and end-of-life care. And the first thing I want to talk about is the advanced care planning. And with the advanced care planning, it is a voluntary process of a person sense discussion between an individual and their care providers about their preferences and priorities for the future. Obviously, managing symptoms in the last few months and weeks is quite vital to heart failure patients, and they really do need, sometimes people are wondering what advice and support they can get. And with having this advanced care plan in place, it helps with better clinic-patient dialogue and a better understanding in a planned care, so that when it comes to the latter part of a person's life, that there's actually a management plan, working management plan in place, which can cause less confusion and obviously less distress to both patient and their family members. And secondly, it can enhance a shared decision-making approach. And thirdly, it's synchronizing advanced care planning across the medical specialities, so that as a result, each person that is in helping in the latter part of life, for instance, you have the community heart failure nurses, which work coincide with the actual palliative care nurses, so that we all have actually got, and then if their preference is, we say hospice, or whether their preference would be that it actually, some people wish to come into hospital for the latter part of their life, but quite a considerable amount of people would prefer to be at home. Hence, when they are actually in hospital, then it would be a priority, obviously, to get those patients home, so they can actually spend their last few days or hours at home with a package of care in place to help and support. And also, it's I think truly listening to their concerns and support is obviously quite important. And to have a plan document in place, as I said, is really important part of all our plan. Then the second part, obviously, is coming to the latter part of life. Sometimes people have an ICD, which is internal cardiac defib, in place. You can have, we say, a CRT-D, this is called, which is combined of both a pacemaker and a defib. And you also have we call a CRT-D, which is a cardiac resistance therapy with a pacemaker, which is for a pacemaker. But the one that we really would be talking about here is the CRT-D, which has got an ICD deactivation part in it. When they're coming to the latter part of life, it is good to have this as part of our advanced care plan, where it is appropriate to have a discussion with the patient and family. And this is to do a management plan, particularly if the co-management was said is come to decision that they do not resuscitate order, and an implantable defib can be confused to patients and healthcare professionals. But the dying patients are at risk of obviously receiving inappropriate and unpleasant electric shocks from the ICD if they develop ventricular tachycardia or ventricular, say, fibrillation in their terminal phase of life. If an IC is not deactivated prior to the death, there is a risk after death that the movement of the body may stimulate the ICD and to deliver inappropriate shocks, which can be actually very distressing. So that would be one part when a discussion is about do not resuscitate, that also to have a discussion in similar time about the ICD deactivation, and obviously to clarify that if they do have a pacemaker, as I said in the CRTD, that to clarify that the actual pacemaker part isn't being switched off, that would be the ICD part. And of course, what would be very important then is to have, in some patients, and there has been a few, where they do make the decision that they would preference is to leave the device on until the latter part. And then that would be important, obviously, that we document this quite clearly so that all people involved in the care actually do adhere to what and to know what the actual plan is in the latter part. Then if we can go to the next slide, please. Okay, and what we were talking to now is about the BMP referral criteria, because part of our job is where we actually do look through the BMP referrals and triage them appropriately. And some things, this is just about what is included in when the referrals come in, is that the NB Pro BMP level, anything is acceptable between 400 to 2000. And that's normally, it can be a 6-week week, although presently that is actually considerably longer than that, because we've had quite an amount of increase in numbers of actual referrals are being made. And secondly, then, if the Pro BMP level is greater than 2000, that would normally be a 2-week wait pathway. And with this, that would be access for a cardiology consultant appointment plus an echocardiogram on the same day, so that you can see if actually heart failure is a cause of the actual symptoms that they're having. And then the exclusion criteria would be patients that are already known to have a diagnosis of heart failure, and if they've had an echocardiogram done within a year, and if the Pro BMP results are over 3 months old, and then also if the patient is bedbound. Housebound patients can be accepted if they're happy to travel, because we have where they can come into us, we say, on a wheelchair brought in by family, or ambulance, or whichever is appropriate. Then if the patient was previously seen in the BMP clinic within a year, and also if the patient is under active cardiology follow-up care. And this is in accordance with NICE guidelines in 2018. And can I have next slide, please? The referral pathway to the BMP clinic, which is for new heart failure diagnostic clinic, is we do have on the ERS, which is a referral form to be completed. And in this, we would like the clinical summary. Ideally should include a recent ECG, but that, as I said, is not mandatory. And this needs to be submitted through the ERS system. And all referrals we usually triage within the first 48 hours, but obviously this excludes the weekends and bank holidays. Referral outcomes are sent back through the ERS with a management plan, an actual, we say if the BMP is greater than 2000, as I said, be 2 week, anything from 4 to 1 less than just 2000 would be the 6-weeker. And those that are under 400 obviously wouldn't be appropriate to be sending to this actual pathway. Referral outcomes, as I said, are then sent back. Non-referrals will be returned or rejected if the forms are not appropriately filled. Sorry, can I have the next slide, please? And this is just what the actual form looks like. But we are in the process of updating this form as well, because I do believe there has been some older forms that sometimes are sent in. And though I think there was one that's quite considerably old, which suggested that because if they had AF or previous MI, that a Pro BMP blood test wasn't appropriate or needed, but that's not the case. I mean, obviously through this pathway, that is what we would need, a Pro BMP blood test. And okay then, and I think there's the other half, is it next slide please, I think is the other part of the actual form, which shows they actually that have the written the Pro and B blood test result and chest X results if there's there in the clinic and examination, and what actual medications they're on or any other relevant data that would be necessary at the time. And then if we have the next slide, please. Is everybody okay with that? Is there any questions? Okay, shall I carry on then? Right, and just to say, also get available community support when referring patients to the community for the community heart failure service. The actual this heart failure with reduced ejection fraction will accept patients that are an LVEF, which is equivalent or less than 40%. And these referrals, which go to, depending on which GP they're under, it will be either the Havering Community Heart Failure Team, or the Redbridge Community Heart Failure Team, or the Barking and Dagenham Community Heart Failure Team. There is other CCGs, but they would be obviously that we would, depending on the GP that they're under, that we would refer them out to the community heart failure teams, but they are the main ones that we deal with. And then we say for patients with heart failure with moderate reduced ejection fractions, we're looking at between 40% to 49%, and heart failure with preserved ejection fraction, which is greater than 50%. These would be advised to consider referral to community matron for fluid management and support. So that, because obviously these patients sometimes come in and they can come in few admissions where they're grossly fluid overloaded, and where they do need some guidance and advice on actual management of fluid overload. And I think that is the last part in it. If there's any questions or.
Thank you, Caroline.
I think we've, yeah, I think
Any
that's.
questions for Caroline?
Yes, we can send you the link of all the
Community.
Community referral email IDs. Everybody has a different one. All three of them have 3 different ones. Thank you. Any more questions? Okay. So can I just ask one single question? What would you do? Okay, maybe helpful to put a date on the referral form. This was updated. Okay. Put a date on referral form. I didn't get that question. What was it? Okay.
Well, I put that, I think, because it's so old forms, I think somebody said that old forms are still in use. And if when the form is updated, the current form, it is put date is April 2021, it's updated, or 22 it is updated, so that we know which is the current or the latest form to use.
Okay, so basically at the moment, most of the surgeries, GP surgeries are providing us the current forms, the referral form. So I will have to see what happened where you cannot, it's not updated. But usually we have the ERS, the form which is there in the electronic referral service is the current form. We are in the, as Caroline has also mentioned, we are in the process of signing another form, which will clearly say this question, that the exclusion criteria will be clearly documented on the front of the referral form. So which all can be rejected, or the forms which don't need to go forward. So that is what we are going to do in near future. But at the moment, we are accepting all the forms.
Okay, thank you.
Thank you. Any more questions? No? Okay. So I hope you guys have an understanding about what we were talking about. What are the heart failure? What do we see? How to diagnose heart failure? I mean, which are the patients you should, when you see a patient, you can say, okay, these are the symptoms. We can get the blood test done. And the basically is, if you find a patient who has symptoms of heart failure, like which includes breathlessness, swelling, and tiredness, and you feel patient doesn't have a history of heart failure, you can do the NT-proBNP. And obviously, if the blood tests are between 400 to 2000, we aim to see them within 6 weeks, and the over 2000, we see them in 2 weeks, though we are currently, our wait time is a lot more higher than this, because we are having an influx of referral. Secondly, if you have in this clinic, the heart failure diagnostic clinic, what is we only see the patient who are like they're not known a history of heart failure. So if the patient is already known heart failure and is under a cardiologist, please refer to the cardiologist as such. Can we, if you have questions? Yeah. Yes, we can give you. Do you have support for patient for bed-bound patient? Is it community matron? Obviously, bed-bound patient, because this clinic includes a patient needs to come here to see the cardiologist as a face-to-face appointment. And so it's for bed-bound patient, becomes very hard for them to be seen in a clinic setting. And many a times patient refuse themselves that they don't want to come in for an appointment. This can't be done by a telephone. So it has to be a face-to-face. So for bed-bound patient, obviously it will be your judgment, and you can ask for a community echo to be done on them and then manage it on basis of that. Sorry. Is there? Sorry, I could see. Is there any other questions I've missed? Late. So not sure, we have somebody message, not sure, we have received referral rejection due for us to refer to for an echo. So the thing is, if you think the patient has all the symptoms of heart failure, and the patient has never been diagnosed heart failure, doesn't have a recent echo in last 12 months, isn't under a cardiologist, you can refer to our clinic and we will provide them an echo followed by a followed by a cardiologist appointment. Does it answer that question? Thanks.
No, that's actually not quite right, because heart failure diagnostic clinic referrals are rejected if no previous echo has been done, even if they have raised anti-pro-BNP.
No, so we are the one who triage the referral. So if we don't have an echo previously, they obviously, and you think the patient is heart failure, there must be another reasons for rejecting it. It won't be that if the patient had an echo in last 12 months, obviously then we wouldn't be seeing them in the diagnostic clinic, because they already has an echo and there's a management plan can be based on that, but otherwise they should be seen in the clinic. So if you have any concern like that, you can send us email.
Yeah, I think if a patient has clinical signs and symptoms of heart failure supported by a raised anti-pro-BNP, then attendance at a heart failure diagnostic clinic should really not be restricted by provision of an echo from GP.
No. Yeah. We don't ask for an echo from the GP. We don't.
What I'm saying is that that's what's happening.
I have been in this post for 2 years. I haven't had anything like that. So if you have things like that, you can happily, we can look into it.
Okay, I'm talking about Redbridge. I'm not sure which area do you cover.
No, we cover the whole three
Okay.
CCGs. So please feel free. You can send us the name. Any more? Dr. Sahicha, do you want to say anything else, or you're okay?
Yeah, I'm welcome to feel free to ask any questions at all.
So I'm assuming there's no more questions, anyone? Nothing in the chat box. No hands either. It was a pleasure having you both, or all of you three. Thank you for attending. It was a good session. The sessions will go up later on this week by next week. And everyone else that's still in the room, could you please fill out the feedback form so we can pass it on to the consultants, and we'll use it for our own personal audits. Be much appreciated. But thank you.
Thanks.
Fida, so